So can I invite our moderator, Dr. Ghanashyam Biswas to the stage, senior medical oncologist from Bhubaneswar. Uh, and I invite his panelists, Dr. M.V. Chandrakanth, medical oncologist from Kolkata, Dr. Amit Kumar, medical oncologist from Patna. We have Dr. Adwaita Gore, who has joined us virtually, medical oncologist from Mumbai, Dr. Bhavesh Parekh, medical oncologist from Ahmedabad, uh, Dr. T.P. Sahu, medical oncologist from Bhopal, and Dr. Mohit Sharma, medical oncologist from New Delhi. So now I hand over the mic to our esteemed moderator, Dr. Ghanashyam Biswas. Over to you, sir.
Recording in progress.
सोमनाथ सर प्लीज आप चेयर पे बैठे हुए नहीं तो चेयर स्टार्ट कैसे होगा फिर हाँ? आधा घंटा कर दो पहला पैनल डिस्कशन
Good afternoon, everybody. So, I feel we'll catch up with our audience slowly. So, let us not delay because already we are delayed for around 15 minutes. So, this session is on supportive care. And this session will be taken up, there will be panel discussion, and it will be taken up none other than by Dr. Ghanashyam Biswas. He doesn't require any introduction whatsoever. Everybody knows him. Dr. Biswas is a pioneer in medical oncology in Odisha, and he is doing a brilliant job. So, I think Ghanashyam, please start your panel discussion.
So thank you sir for the kind introductions. Thanks organizers for this opportunity. So supportive care, so CINV and CIA. So I think both these C is important when you are dealing with cancer, and as we have moved in last 2 decades, the cancer armamentarium, so we are looking at high dose chemotherapy, dose dense chemotherapy. So supportive treatment has evolved so much into that. So our session director, Dr. Sandeep, probably will join virtually. And see, all these are gentlemen. So today, so all men's day. So that's why these are responsible gentlemen, my colleagues today on the panel. So let's start with CINV, chemotherapy-induced nausea and vomiting. So debunk the myths. So on a daily basis, we see patients asking many questions, or in the community, people think that all chemotherapy causes loss of hair and nausea vomiting. So that's not true that all chemotherapy, so as you go on, you'll understand that there are n number of medical drugs which may or may not have a single episode of a nausea vomiting. So these are few of the definitions. So TP, so how do you differentiate between nausea, retching, vomiting? So does it make any difference?
I think it is a sequence of one that leads to other, most likely. Nausea is the most common thing what I see in my practice, and that is the most disturbing, just because a patient is not able to take a lot of things, even very few, lot of them have electrolyte imbalance. And vomiting is, anyway, it's clear that everyone is able to see it, the family member is able to see it, and they bring it to notice. But nausea is something that is only the patient feels. And that's why it is very important for us to talk about nausea when we are administering chemotherapy, because that is a symptomatic, that is a personal thing. And I think that is very, very important for us.
Absolutely. So now we move to the consequences of CINV. So we'll start with Dr. Sondavindu. So, yeah, please. So what are the consequences? So why it is important? So whilst you are treating patients on cytotoxic therapy, so why CINV is important, addressing CINV?
Actually, it's in chemotherapy-induced nausea, vomiting. It not only is a important issue for patient who are receiving chemo, but also it's a psychological impact also. This is most important. Patient has some anxiety, some anxiousness, and before receiving on the date, even day before the date, and some patient even complains when he is entering hospital due to that kind of vomiting and nausea. They are already in a fear of afraid, and they are not able to take. And such kind of patient is sometimes came in our OPD. So definitely CINV is a very good issue for the maintain not quality of life also, but and to decrease the side effect and anxiety and psychological aspect for patient who receive
So
chemotherapy. and
definitely quality of life. So if you are going to use in a curative into suboptimal doses, so ultimately quantity of life also gets affected. And so
Yeah.
there are a component of anticipatory nausea and vomiting for which the patients may not reach your hospital, and ultimately because of supportive treatment, hospital stay, economic burden, and lots of other electrolyte imbalance, anorexia, malnutrition, they are itself a problem. From Dr. Amit, so is there a professional perception and the patient's experience, does it differ? Because if you see the 2004 paper, so now things have evolved. So do you think there are the perception and the patient experiences are different?
Surely. So initially it is the history that chemotherapy causes vomiting. So every patient every time it becomes a new patient, he thinks that the vomiting is the most common complication he's going to have. But in recent years, now vomiting, it is completely basically subdued. With a good management, hardly patients are experiencing. But still it is the most common complication if we are not giving correct antiemetics to the patient right now.
Yeah, so there is a significant difference between as a physician what we perceive and the patient's experience. And this is a 2004 paper, you can see. So highly emetogenic and moderate emetogenic, there is a gross difference between the predictive and the patient's experience of nausea vomiting. So the risk factors for CINV, so Dr. Mohit, so can you just enumerate, so how does the risk factors in a CNV come into place?
See, the risk factors, the most common risk factor is the vomiting during a previous chemotherapy cycle. And what are the type of chemotherapy we are administering, like cisplatin-based chemotherapy, and they are very highly emetogenic chemotherapies. Then we have one thing what I have seen is the female patients, they have more tendency towards this nausea and vomiting. They have maybe due to psychological factors or something. And one thing I have noticed is it should not, you can consider it as a risk factor or something, or it affects the subsequent cycles of chemotherapy also. I mean, subsequent cycles of chemotherapy, patients are very afraid to take the full dose of chemotherapy. Though we want to give them the full dose,
Right.
but
So basically, so we divide into a patient factor.
we do have all the agents also to combat that, but the patient is not able to accept that thing.
So there are patient factors, as Dr. Mohit rightly said. So and there are treatment factors. Treatment can be regimens, and it depends upon the emetogenic potentials. So usually the females, somebody who is an alcoholic, younger patients we have seen, or somebody associated with pregnancies. And as you go on, so the first cycle there is apprehension. So I normally tell my patient that the drug doesn't know the patient and the patient doesn't know the drug. So there is definitely a component of apprehensive anxiety. So subsequently that goes down. So what are the types, Bhavesh bhai, so what are the types of CINV?
Most important is the acute, that's what we all are worried, but there are definitely delayed as well as anticipatory, refractory and breakthrough. The most of the times even we are forgotten to have a delayed vomiting also, and that also cause sometimes problem. And still as a medical oncologist we feel that refractory part might be a concern also. So we have to repeatedly ask that point, nausea and vomiting, before starting every cycles.
So yeah, we have seen that in spite of so much of advancement in these fields, still this remains as an issue. So this diagram shows that so there are patients who can land up an anticipatory. So before, because of the past experience or before they go for the next cycle, and there is acute usually in 24 hours, and subsequently maybe for next few days, so it is delayed. So MB, so what is anticipatory, and do you really feel this exists?
Yeah, definitely. If a patient has had a bad experience with the previous chemotherapy, so the patient will anticipate or already knows that the patient is going to vomit in this cycle. So that is one of the most difficult parts of vomiting to take care of. So for which you may have to start on antiemetics one day prior to giving chemotherapy.
Right. So these are now 4 levels of emetogenic potential. So level 1 is less than 10%.
One point.
Vivek, yes.
Anticipatory is something, sir, that we have faced even years after even the patient has taken chemotherapy in 2 years back or 3 years back, and we are re-challenging. Even then also anticipatory vomiting
So
can
that is
stay.
stored in the memory cells.
Yes.
Yes, boss, sir. So people are active after the lunch. It's good to see.
So I think anticipatory vomiting is something which I will never forget. There was one very pretty young girl, Hodgkin's lymphoma, I was treating very early in my career, which is 20 years back. She finished her treatment and then she met me in the market one day. The moment she saw my face, she started vomiting. So I know my face is not very good, but not that bad either. So the moral of the story for younger colleagues is first cycle में nausea vomiting नहीं होना चाहिए. जो भी कुछ करना है करो. Lorazepam दो और fosaprepitant दो, but first couple of cycles there should be no nausea vomiting.
Right.
Vomiting, that may be new word in the Google.
It's like anticipatory bail. So level 1, 2, 3 and 4. So normally in discussions we discuss about moderately emetogenic. So from 30 to 90% and more than 90% is what is level 4. So these are different emetogenic drugs. So TP, so the regular neoadjuvant, adjuvant, AC or EC. So you consider that as moderate or high?
High. Anthracycline or any platinum is something for me will be high. I've seen across NCCN guidelines, we look across maybe 10 years back, it has come from a moderate now into high group.
So that difference is there, you are right, because if you give less than 60, it becomes moderate. If it is more than 60 of adriamycin, then it becomes high. Carboplatin more than 4, AUC becomes high. Less than 4,
I was only surprised with the carboplatin. All of us once in 3 weeks give more than AUC 5. That's what. And actually,
so now Pacli carbo, very common combination. So what is
that's the point. So actually, it is classifies into a highly emetogenic is something I am not able to digest. And I, in my practice till now also, give the patient palonosetron or a ondansetron with the dexamethasone. And I can tell you, they don't come with, I don't have faced that problem as I do with cisplatin or even sometimes the anthracycline.
Okay, normally you give a AUC 5, that became a highly emetogenic.
Yeah, as per data.
Comes as a mild.
So as per data, so you always have to think of the higher part and do it. But I somehow am not convinced. I want to know from others how it is. The AUC carboplatin 5 now classifies into a highly emetogenic, means more than 90% chance of getting vomiting. I am not sure.
So MB, so IFOS adria and IFOS if you use it in a sarcoma, so you consider it as?
That is high risk.
So these are low emetogenic, minimal emetogenic?
For IFO, it's easier for us because you either combine with cisplatin or adriamycin. And anyway, ifosfamide more than 2 grams is anyway, I mean, highly, the adria is highly, and the platinum is high.
But IFOS less than 2 again becomes moderate.
Yeah. But you anyway don't give single agent in most of the cases.
I think might be there may be a more nausea rather than vomiting. So practically, most of this peclicarbo
CINV.
Yeah.
So nausea,
Yeah, that's what.
The main dish is also there and the sweet dish is also there.
Even if a drug is classified as a moderate emetogenic, but in most of the patients, those moderate, what we have seen in the practice is that moderate emetogenic drugs in combination with the anticipation that they have, though it is better to take it as a highly emetogenic and treat accordingly.
No, we are discussing the carboplatin AUC more than 4, that part only.
So anatomy, so we know that brainstem vomiting center, area prostrema, chemotrigger trigger zone, so these are all there. So what is important here is that two neurotransmitters, before you understand the drugs, so substance P and the serotonin. So these are two important, which plays an important role as a neurotransmitter when you talk of CINV. And that is the reason that in acute, that is within 24 hours, so predominantly serotonin dependent mechanisms, peripheral. So in a delayed vomiting, it is because of a substance P dependent mechanism. So that's important to understand that. So these are because of a different neurotransmitter. So one is the serotonin and the other is a substance P. So evolution of antiemetics, so though cisplatin got into a chemotherapy protocol in 1978, and the first guidelines in the NCCN about chemotherapy-induced nausea vomiting came in 1997. So that is long back. Then came the first ondansetron, which was tried with the metoclopramide, then dalanosetron, then Ghanashyam. So this is how things evolved. Then we moved to palonosetron, then apripitant, fosapitant, and now we have NEPA. At this moment, we have NEPA with us, and that got again 2015. So these are sites of action of drugs for nausea vomiting, starting with the higher cortical centers, then the vomiting centers, labyrinths. So among the 5-HT3 antagonists, so now most of us has moved from MD medicine to now then medical oncology. So do you think when you are given a reference from a medicine patient comes, so many of our colleagues, we left and right use ondansetron, and many a times without any factor we have seen the patient, there is sudden cardiac death. Most of these patients complains of a constipation, headache, and again for headache you try to give some medicines for constipation. So do you think routine use of these 5-HT3 antagonists has given rise to this, Mohit?
Yes, maybe.
So overuse of these drugs, and many a times so these are drugs or lots of interactions. So Amit, so what do you have to say?
Surely. So since they prolong QTC and this 5-HT3 antagonist, before prescribing, we always have to check the interaction. So
especially elderly patients, especially with the cardiac comorbidities, especially somebody who is bedridden. So probably we need to have a judicious use. So headache is common, so 1 out of 10. We can see constipation is common. And QT prolongation. So we are so concerned for antibiotics, many other drugs like ribociclib, but these are common drugs, and probably एक बार start होता तो फिर बंद नहीं होता, discharge तक you continue it.
For Ghanashyam, it is just like that. 3 mg if you have given to any patient, it will be only severe constipation. So, and the vial comes both in 1 mg and 3 mg. So one have to always practice that 1 mg thing for Ghanashyam.
So then we moved into apripitant. So TP, so how has been your experience with apripitant?
I'm pretty happy with that, and I think it is for anything that is moderately to high emetogenic.
In 10 patients you have prescribed apripitant. In how many patients you have seen that they haven't taken the second day or third day drug?
Nowadays, unlikely because it is in the initial when it came, I did find those patients coming back with the day
through. I still see patients who have missed it.
So I was coming to that. So it's basically what I feel is our counseling and the time the nurses discharge, if it is clearly told, they will take it. In the initial 5-6 months, I could find patients coming with that key for the next cycle. But nowadays, it's not happening. That has been absolutely zero for me. And I found we have to spend time while we discharge them.
प्रैक्टिकली विश्वास कई बार ये ऐसा है, सर हमने ये समझा था कि जब वॉमिटिंग हो ना तब लेने का, तो वॉमिटिंग नहीं हुई दूसरे दिन, इसलिए हमने नहीं लिया. आपने बोला था कि वॉमिटिंग के लिए एक गोली है. So again we have to explain कि either it happens or not happens.
Probably that was the reason that IV fosapitant and that NEPA became more important, because at least the patient takes in the hospital.
Correct.
So any other usage of apripitant you have used in the past? Any other indications besides nausea vomiting? There are TMS paper?
I use it basically before this. I got just.
Besides nausea vomiting, any other usage of this? Chandrakanth के time में था paper? नहीं.
Mostly in the case of cough, intractable cough, if the patient is
so
having,
especially advanced cancer lung, so intractable cough. So many a times we give morphine, So this is one, Dr. Banita and Kumar Prabhas, they presented. So this is one drug, good drug, though that was 80 milligram they have tried. So you see, aprepitant can cause severe asthenia, hiccup, dizziness, heartburn, so diarrhea in 10% patients. So we should not ignore these side effects, because many a times we talk about antibiotic-induced diarrhea, chemotherapy-induced, but these are again certain common drugs. So lot of interactions and lot of unnecessary side effects, and for which the patients get more drugs added. Advait. So,
yes, sir.
Yeah. So, how important is the drug interactions for these sort of 5-HT3 or for aprepitant or even fosapitant? So, how important is that for you?
I think, as we were discussing about the QT interval prolongation with the 5-HT3 inhibitors, there is also cytochrome P450 which does get inhibited by this, and there are interactions. We know many of our chemotherapy drugs also get eliminated through those pathways, and inhibition of cytochrome P450 does increase or decrease the half-life of these drugs and can add on to the toxicity.
Yeah, so that's important, because common drugs like docetaxel, paclitaxel, etoposide, IPOS, there are so many other vincaricolides. So increased plasma concentration. So many a times we see unexpected toxicity. So I think that probably we are ignoring this interactions part. So probably we need to keep a chart on our table and see. So coming to fosapitant, so we know that this is a 150 milligram single dose, and so this also has certain side effects like constipation, asthenia, and diarrhea. So management guidelines. So what has been your experience, Bhavesh sir, so on NEPA?
It's a good drug, but still I feel that so many other like oldest like ondansetron or even metoclopramide, and we had so many other anti-emetogenic drugs. So I think that this drug is also for some niche group or some specified group where I feel it's a good emetogenic drug.
So TP, any experience of the generic one?
No, but
because there is a huge cost difference,
yeah,
6,000 and this is 2,000.
Yeah, apart from that, is basically what I believe, and that you have to, this is a combination of the palansatron and the nupitant. So you have to, if you are doing it in any form, let it be a fosaprepitant or aprepitant or separately, the thing is that it has to be given. And this combination or a single 5-HT3 along with the aprepitant group of drugs, even also given, are equivalent. So the good thing about this is you have IV and oral, the oral is there, the aprepitant doses is, the nupitant doses is different, the palansatron dose is different, but the basic message that should go forward is you have to give a combination of this if it is you are dealing with a highly emetogenic.
Especially for a treatment protocol like 5 days protocol, 4 days protocol, so that's the best drug, because for multiple days chemotherapy protocol, so that's the only choice you have. Otherwise, palansatron you need to give on day 1, day 3, day 5.
For a multiple day, I don't know how the others have, but I have started using the aprepitant, and I redose it on day 4 and day 5, the 80 mg. So I give the aprepitant day 1, day 2, day 3, and then 80 mg I give it on day 4 and day 5. And I give, and then I give a palansatron on day 4. And there is more than one trial telling you about the multi-dose chemotherapy, and even NCCN have advised in their protocols. And for me, for last 2 years I've been using it, and there has been a significant reduction in the nausea, vomiting.
Actually came into picture because of this multiple days chemotherapy.
Yeah, so I've been using that, and aprepitant tablet being so cheap, now 150 rupees odd, it
So
really
Amit,
takes
so
up.
the original versus the generic one, so
Yeah,
you have an experience?
Yeah, I'm using both. So it's this response is good with the both drugs.
Yeah.
I haven't found anything
So
extra.
have you ever faced, so if you have seen the original Akangio,
yeah.
so there are 3 boxes. So patient
are
पूछता है sir आज कौन सा खाने का? Actually the 2 boxes are empty.
Yeah.
2 boxes are empty, and somebody posted in our medical oncology group also sometime back. Those are only on blank. So Advait,
I also feel, sir.
so what is your take on benzodiazepine? So lorazepam and the olanzapine.
Yeah,
what-
so Lorazepam we do use essentially for patients who have a lot of anticipatory nausea. It does work well in patients pre-initiation of chemotherapy. Most of the patients we start it one day before and continue it for 3 to 4 days during the chemotherapy so as to make sure that the patient has good amount of sleep. It also is important not just to control the anxiety, but also make sure that the patient has an adequate 6 to 7 hours of sleep before the chemo, because there are studies which clearly show that if the patient has slept less than 7 hours the previous night, the incidence of CINV is much, much higher.
So if the patient sleeps well, the treating physician also sleeps well. So
Yes,
he's
I think
not bothered.
that is very important.
So
One
how,
point
how
which I want to make, one point I wanted to make on the IV fosaprepitant was that it's the IV fosaprepitant. It's preferable to be given through a PICC line or a port because it does produce considerable amount of thrombophlebitis. So that is one problem which I have seen in my practice. I know my colleagues whether they have noted the same.
yes, any comments?
For olanzapine, I want to make one comment is
What
even
did you
giving
say?
suboptimal doses of olanzapine, what I have seen is it helps a lot. Even if you give 2.5 milligrams of olanzapine, that helps a lot. I mean,
So yeah,
it is
so
very
the
good for the,
recommendation is
at least for
5
the
to 10,
physician.
but I also use 2.5.
2.5
Yeah.
has done wonders. At least it is very comfortable for me. I don't know how for the patient, but it's very comfortable for me.
For olanzapine, the most of the patient is complaint of drowsiness and these things. So I use 5 mg, and I preferably advise my patient to take it at night before going to the sleep. That is
What is Advait tell?
So you were asking that, so any patients on an IV fosaprepitant, so lots of thrombophlebitis.
Yeah. Olanzapine is something which just really should be addition in most of our chemotherapy for moderate and highly emetogenic. And I use it quite well. And I use it on day 1, day 2, day 3. And that's what it is. If it's highly emetogenic, even I use it for 4 days also. And 5 milligrams is where I start.
Make a trial of that, so 3 versus 4 days. No?
No, it is there. If you look at the highly emetogenic protocols for NCCN, it is day 1 to 4. For moderately, it's day 1 to 3. It's already there.
Yeah, but
And
the package comes as 3, no? So 125 kg. So uske liye aur ek naya.
The
So
olanzapine.
so we discussed about the interactions of 5-HT3. So see about aprepitant, nutipitant, and rolipitant. So these are all potential drug-drug interactions. So if you see all these lists, so एक prescription बनाना तो difficult हो जाता है. So MB, so you have planned a protocol, suppose EC. So do you write on the bracket it is a highly emetogenic or a moderate emetogenic? Then so do you make a note of that normally?
No, sir. I mean, you have to look into the anti-emetic regimen and understand it's highly emetogenic
Amit,
or not.
लिख दो prescription में
And
when you
moreover,
advise
and moreover, sir,
EC, so bracket में
if
highly
you
emetogenic नहीं? So I've seen many colleagues from KDA recent days. So right, so HEC.
We write in the consent form, na? We write in the consent form.
Yeah.
Not in the prescription.
So to conclude the CINV part, so it's a debilitating side effects, almost 2/3 of the patients, most fear. Despite newer anti-emetic agents, CINV remains an issue. Unmet needs, optimizing control, managing patients, and adherence to the guidelines. So overall, worsening of quality of life if you really don't address the CINV part. So coming to a cancer and chemotherapy-induced anemia. So again, underestimated problem like the nutrition part. So 3/4 of cancer patients have anemia at their sometime during their illness, and most of them are hematological malignancies, and usually at the fag end of the patient's cancer journey, so this becomes more important. So the causes can be nutritional deficiency, hemolysis, blood loss, infiltration of the bone marrow by tumor cells, and myelosuppressive chemotherapy, maybe at times radiotherapy. And cancer also is an important cause of anemia of chronic disease. So these are consequences. So starting from Mohit, so what are the consequences from moving from CINV to CIA?
The first important thing is definitely the compromised quality of life. And the patients, they have asthenia, fatigue, and poor performance status. I mean, even the thing is, sometimes you're not able to even judge the performance status of the patients adequately, because that is very important, to assess the performance status while giving chemotherapy. So if the patient has anemia and fatigue, you are likely to downgrade the performance status. Suppose he has PS1, you are likely to take it as PS2.
Right. So, rightly said, so quality of life, fatigue, performance status, cognitive functions, and premature death, many times because of treatment related. These are National Cancer Institute anemia scale from grade 1 to grade 5. So these are anemia and chemotherapy. So agents and regimens. So Bhavesh sir, so what are the agents, chemotherapeutic agents or regimens? So where you see very frequent anemia.
I personally feel that especially docetaxels and there are some medicines like we commonly use combination of paclicarbo also, that definitely there is anemia. Sometimes still I feel in India we had that guidelines like below 12 or below 10. Sometimes even up to 10s we are not considered anemia. By definition
In
it is
head and neck
anemia.
cancers, anemia is common.
Yeah.
Gemcitabine based therapies.
Again, hematological toxicity. So gemcitabine is also most of the times when we have a 8 days protocol, day 1 and day 8, then most of the times we have to give factors or the drugs to treat the anemia as well.
So Advait, so what are the risk factors for CIA?
So the main risk factor is poor nutrition of patients. That is the most commonest cause for iron deficiency in Indian subcontinent. Many of our patients do have a baseline hemoglobin itself, which is hovering around 9 or 10, especially females. The other risk factors are using chemotherapy agents which have higher hematological toxicity, just like what Dr. Bhavesh said, and patients who have GI malignancies, disease related itself, where blood loss is one of the common factors for the disease.
Right. So TP, how do you evaluate now CIA?
Uh, I would definitely look into the causes of anemia, which would be might be chemotherapy or induced, or could be disease induced, or could be a nutritional. So best thing would be to do a simple blood test with a PS comment, and the type of anemia is so very important for us to evaluate what is happening. Also look at the rapidity of fall in hemoglobin. That also would point towards, especially in GI cancers and head and neck cancers, many times I've seen bleeding is one of the cause for rapid fall. So I would look into these factors, the RBC morphology, the history, the site of the tumor, and the chemotherapy I'm giving.
So MB, so normally in a patient who are on chemotherapy, we look at hemoglobin, WBC platelet, and neutrophil. So how many times we see the RBC
if there is anemia, I see. And if you are doing hydroxyurea, I don't know how many of us, I've seen the MCV and MCS rising. So that's also indicator for me for a lot of my chemotherapy things that okay, it's not. But yes, if it's anemia, you have to.
So many times you see the surgeons writing hemoglobin PCV.
That's wrong. So why I'm telling you is invariably 2 to 3 times in a year, not very common, you would find a vitamin B12 folic acid deficiency to be the cause for thrombocytopenia with anemia. And you would see that.
So all patients, MB, so you go for folate, B12 and iron?
No.
Profiling?
No, sir. I mean, there has been some sort of evidence where if you unnecessarily supplement vitamins, it shortens the progression-free survival. So we shouldn't indiscriminately use multivitamins.
So Amit, so what are the goals you want to achieve in a CIA?
Basically, it's the patient's quality of life, but his fatigue has to be settled, the symptoms has to be controlled. The first thing, basically, we take a cutoff initially of 8 for chemotherapy, but now I see that even with the 7, if the patient is good enough, I can go away with the chemotherapy and not going to supplement with either anything for those group of patients. So it's the symptom of the patient is the first thing which I take care of regarding this, and then the hemoglobin something around 8 to 10.
So improve HB levels, quality of life, and to reduce the need for RBC transfusion. And everybody of us faced during this COVID pandemic how difficult it is to get a transfusion done. So normally, so once you have documented anemia, so probably, so you need to go to the red cell indices of these patients, and then you find out the iron stores, and then you decide, so that with the TIBC, serum iron, and the saturation. So whom do you consider for transfusion? So Bhavesh bhai.
For me, a clinical or especially like quality of life and patient came or the performance status when go down, and especially when I'm treating my curative patients, and that curative patients or chemotherapy I have to delay it because of the hemoglobin low, then blood transfusion is required. But nowadays, initially, we are giving blood transfusion, but with so many new drugs available with us, I think less and less blood transfusion and more alternative of blood transfusion also may help. And that again, if we anticipate again the early log or early fall of hemoglobin, then we can avoid blood transfusion.
So Swarnabindu, so besides blood transfusion, so what are the other how do you manage
Yeah,
this?
actually, there is an, apart from these, we have to look up the iron deficiency, is functional iron deficiencies there or not, with the total iron panel, TIBC, transferrin saturation, ferritin, as well as total iron. If patient is repeated transfusion, even after repeated transfusion, hemoglobin is not maintained more than 10 and there is functional iron deficiencies there. There is some stimulating agent like erythropoietin stimulating agent we can use sometimes in palliative settings. Apart from these, there are some oral IV formulations. If MCV and others is suggestive of iron deficiency, we have ferric carboxymaltose that are commonly used and to correct the anemia and hemoglobin level. But it requires multiple doses, minimum 3 to 4 doses in subsequent cycles. So,
So TP, so when are you not going to use erythropoietin or darbepoetin in a cancer chemotherapy?
I would not use
So
it.
anemia is there.
Yeah.
So when you are not going to use these drugs?
If there is a veno thromboembolism history, I really refrain from it. I try to avoid it. If the EPO level, I sometimes have seen if it is high, I would not much venture into it. So these are the very few things which I look into when I don't.
So you can see the NCCN. So ESAs are not recommended. Patients with cancer not receiving chemotherapy. Patient receiving non-myeloablative therapy. Patient receiving myelosuppressive chemotherapy with a curative intent. So it has been only given in a palliative setting. So
Yeah, this data comes from the EPO study from Johnson's, where
Right.
they found a detrimental effect.
So MB, so have you used darbepoetin 100, 200, 500? Any experience of 500?
I think you have the best experience because you have a published paper. So we use more of 200 because 500 one-time cost is too much, which patient says that it is more expensive. It is
give
more
a
expensive than
pack, 2 to 1,
chemotherapy.
2 plus 1.
Yes, sir.
So 100 can be given weekly, 200 2 weekly, and 500 3 weekly you can give it. So this can go with chemotherapy cycles.
Basically, I have used in one patient 500, it's going on, but even after 2 doses, no response I'm still getting. So I might be by next
So
dose
maybe
I will decide.
as TP said, so you get an EPO level done. So erythropoietin therapy, so risk of thromboembolism, possible increased mortality and tumor progression, risk of hypertension and seizures, risk of pure red cell aplasia. So Advait, any of this toxicity have you seen with any of these ESAs in your practice?
Thromboembolism is a common thing. I think the important point is when we are using ESAs in a palliative setting, we should be setting a target hemoglobin that we need to achieve. I think for a practical purpose, a hemoglobin of anywhere between 11 to 12 is what one should target, should not go beyond that, because when the hemoglobin level of more than 12 is targeted, most of these thromboembolic events are much more common.
Right. So Mohit, so when are you going to give iron injections and what is your experience with the newer third generation? So you mean isomaltose and the FCM?
See, if I document low levels of serum iron and increased levels of serum TIBC, then I prefer giving IV iron therapy than oral because of gastro side effects of the oral therapy. IV is well tolerated and with it can be and you are sure that you are given a shot. If you go for oral therapy, then patient may stop using
so
it.
your experience with IV iron, FCM, isomaltose?
Yeah, both are good drugs and we have to give it's the appropriate use and for a long term, then definitely we will get benefit.
The main point is how you should choose is if you have a 2 to 4 weeks time to look at the hemoglobin, and if you don't, you're okay with that part. Because if you want a rapid increase, the transfusion is the only way to go forward. Or if you have a cardiac comorbid patient or patient with dyspneic because of anemia, then you have to go for transfusion. And if you have that advantage of having that 1 month time on which iron growth of the hemoglobin is good, then I think that iron works. And before iron starting, I probably, in my practice, I don't know how others, I do document iron deficiency. So that's something which I do.
So iron deficiency is common, yes, indeed.
So we need to check whether it is a absolute iron deficiency or a functional. If it is absolute, oral is okay. If it's functional, especially if you are giving ESAs, then we should give IV iron.
So you know that iron deficiency, so dietary, so oral iron, IM, IV, blood transfusion. Thank you. So these are ways you can treat these iron deficiencies. So normally we say, so oral irons are cheaper, effective, but yeah, so rightly said, so they come with so much of toxicities, and many patient doesn't want to take. So then came the parenteral iron therapy. So now we have 3 generations. So now FCM and ferric isomaltoside is the 3rd generation. So probably during our MD days, we used to use the iron sucrose and the other 1st generation drugs. So FCM is taken by the RES in no time, and after that iron is delivered to the iron binding proteins, and there is almost no risk of. So Advait, so this newer iron, FCM and isomaltose, so any hypersensitivity have you faced any time, which is to be a problem for other irons?
So we've had one patient with FCM who's had a sudden cardiac arrest following the infusion. We really don't know whether the patient was hypersensitive or not. And there was a code blue. Luckily, we were able to revive the patient. That is only one episode that I distinctly remember with IV iron that we've had.
Absolutely. I had also 2 patients. So this is FCM efficacy, pre-FCM. Within 5 weeks, you can see the jump in HB. FCM versus oral therapy, you can see the pink taller bar at day 21 and day 42. So IV iron versus oral iron. So you know that. So if the gut is absolutely fine, so you can use it. So some advantages: effective, rapidity of response, no test dose required, no GI intolerance, up to 1000 milligram. So how do you calculate the dose, Mohit? So how much to give the iron? So do you really follow this formula? Iron need. So there is a.
So in clinical practice, earlier we used to calculate the dose, but now 1000 milligram is the dose which we are giving for every patient upfront.
So yeah, so there is a formula. So the iron need, can we calculate the body weight into 15 minus the actual hemoglobin plus into 2.4 into the iron store. Otherwise, the simplified score you can keep on the table. So if mild, so you require the patient's hemoglobin, the body weight, and then you can calculate. So maximum is 2,500.
More commonly in our practice, we give 1.5.
Right. So these are administration by IV use. So no more than 15 milligram per kg. So FCM you can give in 15 minutes. Isomaltose you can give over 30 minutes. So up to 1000 milligram in one go, not more than that in a week. So this also has some adverse events. So hypersensitivity reactions, though it is rare with the 3rd generation. So hypophosphatemia, hypertension, and at times flushing and dizziness. So these are difference between isomaltoside and FCM. So how do you treat anemia of chronic disease? So Swarnabindu.
Anemia of chronic disease, usually we have to look up the ferritin level and these things, iron profile. And sometimes if patient is, I'll prefer oral therapy, those who are tolerant to able to take oral agents, so oral hematinics. Otherwise, sometimes supplemental with the parenteral iron. But definitely the parenteral iron EPO I have not preferably used in anemia of chronic.
So oral iron, so no, parenteral iron yes, oral iron plus EPO no, parenteral iron plus EPO. So any other usage you have? So Tarini was saying. So restless leg syndrome, there are patients who complain of restless leg syndrome. The mechanism is in the substantia nigra. So give 1 gram of IV iron So there is a remarkable 70% improvement. That's important. So to conclude, so largest amount of evidence in the treatment of CI has been there, and
One thing is like we are talking about iron in anemia, but we should also talk about vitamin B12 and folate, especially in Indian patients, female patients.
especially
they
Marwadis, Agarwala, Bansal, they come. So I've seen
so we
these
should not
patients.
forget B12
Absolutely.
and folate deficiency.
Even D3.
So we come to the last slide. So the time is always right to do what is right. So by Martin Luther King, and I thank my first year DM student who helped me preparing these slides, Antara Sanyal and the Santosh Reddy. Thank you so much, Chairperson, and my colleagues on the dais. Thank you.